Hello and welcome to my channel for patient and caregiver with Parkinson's disease. My name is Luis Sayas. I am a board certified internist, neurologist, fellowship trained in movement disorders, and ex-physical therapist. Today we are going to discuss about the management of sleeping problems in the setting of Parkinson's disease. Many of my patients tell me, doctor, I cannot sleep. What can I do? A very common problem in the clinic. Chronic insomnia is one of the most common symptoms, complaints that we have in the general family practice of internal medicine clinic. It's almost always multifactorial. In Parkinson's disease, is one of the most common non-motor symptoms. For example, in a survey from 1998, approximately 98% of the patient had experienced some issue sleeping at least some point during their disease. The question to answer is, what can we do to help? So let's start talking about REM sleep behavior disorder. The sleep cycles are mostly divided into areas: non-REM and REM. REM means rapid eye movements. So during REM, you are supposed to be paralyzed. So it's the stage of sleep that you are dreaming, you have your dreams, but you are supposed to be paralyzed except the diaphragm, which is the muscle of the breathing. In Parkinson's disease, you are not paralyzed. You are actually acting out your dreams. RVD, or REM sleep behavior disorder, is present in Parkinson's disease approximately 50% of the time. So it's pretty common. It's more common in other neurodegenerative diseases such as multiple system atrophy and dementia of Lewy body. But in Parkinson's disease, it's approximately 50%. So those patients are acting out during the sleep, punching, kicking, moving a lot, screaming, having vivid dreams. And those dreams are not good dreams, are actually very unpleasant. Like somebody chasing you, you are chasing somebody, you are fighting, you punch, kick. And the problem with that is that you might have a trauma because you might hit the wall, you can fall from the bed, that kind of things. That's the main concern. What to do with those patients? Number one, sometimes we don't need to do anything. If these symptoms are very mild and not affecting the patient or spouse or not causing any trauma, or patients are not at risk of having trauma, then you don't have to do anything except education. Okay, and it's very important that you understand the safety precautions, such as, for example, you need to remove sharp objects, lamps from the sleeping area. Sometimes we need to put mattress on the floor next to the bed, or some bed rails, just to prevent you to fall down from the bed. Sometimes we need to try to decrease the antidepressants, because some antidepressant might make RVD worse. So one of the antidepressants less likely to cause or to worsening RVD is bupropion. But the other ones that we commonly use in the setting of Parkinson's disease, such as venlafaxine, I use a lot of venlafaxine, Lexapro, and sertraline, Zoloft. Those medications might exacerbate REM sleep behavior disorder. If we need to treat with medication, then we can consider two main medications. One of them is melatonin, which is an over-the-counter supplementation. Melatonin is a hormone that we actually produce, but we are going to give you more of that hormones and somehow improve the RVD symptoms. The doses that I use is usually, I start with 5 to 15. Usually start with 5 and then I move to 10 if needed. I tell the patient to take it 1 hour before bedtime. If that doesn't work, I try clonazepam, the lowest dose possible before bedtime. These clonazepam tend to be pretty effective. The problem is the side effect that you might have with clonazepam. Um, so the main side effect is a hangover side effect. It's like when you wake up early in the morning, you feel very sleepy, still sleepy. Increase the chances of you having a fall. Thinking problems, or when I say thinking problem, I mean memory issues. It might actually worsen untreated sleep apnea. So make sure that that you don't have a sleep apnea, because what happens is when you use clonazepam or any of those muscle relaxant agents, it might cause relaxation of the airway. So your symptoms of sleep apnea will get worse. You will have more snoring, and so it would be a big deal. So let me summarize very quick. First choice would be melatonin. I start always with 5. Some people start with 3, and that's fine. I always start with 5, and sometimes I go to 10, and a few times I go even to 15, and some patients even need even more than that. Melatonin is very safe, and if that doesn't work, I add or switch to clonazepam. Let's talk about sleep fragmentation. Sleep fragmentation is the most common sleep problem in the setting of Parkinson's disease. Almost every patient at some point will have this problem. It's common in the general population, but it's even worse in patients with Parkinson's disease. Before blaming Parkinson's disease by itself, you need to rule out secondary causes, okay? The most common one, or one of the most common one, is having overactive bladder. Overactive bladder is very common in the setting of Parkinson's disease. Imagine that you wake up 5 times, 4 times at night to urinate. So what happened? You will have sleeping issues because, well, some patients actually can go back to sleep, but still waking up more than twice is too much. So sometimes we use medication to calm down the bladder, okay? At some point, we will do a video about these common non-motor symptoms, which is overactive bladder. We have medication for that. One of the things that we recommend is to try to avoid excessive fluid intake late during the day. For example, stop after 5 p.m. Try to avoid fluid after 7 p.m. Otherwise, you will be urinating a lot at night. There are some medication that we use in the setting of Parkinson's disease that can cause insomnia as well. So one of them is selengilin and amantadine. So that's why you need to use those medication in the morning. If you use those medication later in the day, they will cause insomnia in many patients. So I always tell patients to avoid taking these, specifically these 2 medication after 3 p.m., assuming that you go to bed at 9 or 10 p.m. Other medication or group of medication that might cause sleep fragmentation is a chronic use of narcotics. Okay, these somehow exacerbate or cause a sleep fragmentation. Very important that you rule out sleep apnea. Sleep apnea is a very common phenomenon in the general population and also in Parkinson's disease. So if you are suspecting that you are having a sleep apnea, tell your doctor, and you will need a sleep study. There are other problems associated with Parkinson's disease that might actually affect your sleep pattern as well, causing you to wake up multiple times at night. And this is what we call sometimes akathisia. Akathisia is the sensation of restlessness. You need to move. You need to move your legs. You need to walk to feel better. It's a very, very bad sensation inside your body. You feel like a tension sensation. That might be actually a off phenomenon, and sometimes it's not related with being off at all, which is part of the Parkinson, and very difficult to treat. The other main symptoms that you need to treat, because it might be a secondary cause for insomnia or sleep fragmentation, is depression and anxiety. Very important that you treat those conditions. In people with Parkinson, the good thing is that they actually respond to antidepressant because there is a deficiency in serotonin, which is a chemical in the brain. So you're replacing that, so patients feel a lot better. So remember, your body will follow your state of mind. There are other problems that you need to try to rule out. For example, RLS, restless leg syndrome, is a very common phenomenon in the general population as well. And this is, again, is like having akathisia, but located in the lower extremities. But sometimes it goes to the upper extremity as well. Uh, so this is a sensation that you need to move, and when you move, you feel better. And this is the criteria in order to make the diagnosis of RLS. The good thing is we have treatment for that. Many of the treatment that we have available for RLS are similar or the same medication that we use for Parkinson's disease as well. Other problem that is very common in our population is painful neuropathy. So make sure that your doctor rule out common causes of neuropathy, such as vitamin B12 deficiency and pre-diabetes or diabetes. One problem that might affect your sleep is being off at night. Being off at night. So when you are off, I mean that your carbidopa, levodopa, your levodopa, your dopaminergic medication are out of your brain, out of your system. So you have, again, those Parkinsonian symptoms affecting your bed mobility, causing you to have resting tremor, especially during the early first stage of sleep. Because remember, when you are sleeping, all those movements goes away. The majority of the abnormal movement goes away. There are few movements that's still present while you're sleeping, but that's another topic. But tremors goes away when you are sleeping, except during the initial stage. And there's another common problem which we call off dystonia. Dystonia means abnormal posture. Usually it's a painful contraction of the toes, a crawling flexion of the toes, usually in the morning or 4 a.m., 5 a.m. And it's an off phenomenon. And it might respond to levodopa, but it might not. And so some patients require botulinum toxin, like Botox injection or Xeomin injection. This is a very nice paper published in 2019. It's an evidence-based review showing that rotigotine, which is a Neupro patch, might help in patients with a sleeping problem, improve the sleep quality and maintenance. However, you need to be aware of the side effect of dopamine agonists, such as sleep attacks, compulsive disorder, the swelling of the legs, and many others. So excessive daytime sleepiness is a very, very common phenomenon as well in the setting of Parkinson's disease. Approximately 20 to 50% of the patient have this problem. Most likely is related with medication that we use in the setting of Parkinson's disease, especially dopamine agonist, but also can be seen with levodopa, with Ritari and Cinemet, but it's most likely associated with the medication. Plus, superimposed to just having Parkinson's disease by itself and not able to sleep well at night as well. The main problem or the concern is driving safety. It's a big issue because many patients, approximately 20% of the patient, might have sleep attacks. So you have to be careful when you drive, because you can have a car accident. So what to do with those patients who are having significant amount of daytime sleepiness? Number one, you need to rule out secondary causes, specifically sleep apnea. Every patient who is having daytime sleepiness, I'm not talking about fatigue, I'm talking about daytime sleepiness, which is different. It might be combined, but they're totally different process. And you need to rule out sleep apnea. Okay, very important. We have good treatment for sleep apnea, and if you don't treat sleep apnea, the chances of you having a stroke, heart attack, arrhythmias, memory problems, depression, anxiety increase significantly. So it's very important that you take care of your sleep apnea. Sometimes we need to adjust medication. For example, Cinemet, carbidopa, levodopa, sometimes cause what we call peak dose side effects. One of them is drowsiness, feeling sleepy. So sometimes using a medication or formulation with less peak might decrease the chances of you feeling drowsy, such as the CR, continuous release formulation, or the standard release formulation. That's an option to try. Remember that in Parkinson's disease is a trial and error, okay? Every patient is different, so you need to try. Also, sometimes we need to discontinue the dopamine agonist. When I say dopamine agonist, I'm talking about pramiprazole, ropinirole, apomorphine, or the patch, the rotigotine patch. Sometimes we need to discontinue those medications. And remember, you cannot stop cold turkey those medications. You need to taper down those medications. And even though that you taper down those medications, many patients will develop dopamine agonist withdrawal symptoms, which is pretty bad, severe. Sometimes we try the use of selengilin. Selengilin is actually metabolized in amphetamines, and you use it in the morning with breakfast. And it's 5 in the morning, 5 milligrams in the morning, and 5 milligrams at lunch. That might help in some patients. Modafinil also, some people use modafinil to treat daytime sleepiness, especially in the setting of obstructive sleep apnea. It's actually approved by FDA to treat daytime sleepiness in the setting of sleep apnea. But sometimes we use just in patients with Parkinson. And it might work. We have some data. I start with the lowest dose possible, and then I go up progressively. So, general recommendation: sleep hygiene is essential. Sleep hygiene. So everybody with sleeping problem need to have a good sleep hygiene. What is that? Number one, you need to go to bed at the same time. If you go to bed at 8 p.m. and then the next day you go to at 12, it's not gonna work. You need to have a pattern. You need to have a schedule. You need to wake up at the same time. It doesn't matter if it's Saturday or Sunday at the same time. Otherwise, it's not gonna work. Bed only for sleep and sex. That's it. Why is that? Because some people use the bed to read and to play with the computer or doing stuff in the on bed. It's not going to work if you do that. So you need to prepare your brain that when you go to bed is to sleep. Okay. If you become very anxious at night, if you wake up in the middle of the night and you feel very anxious and you cannot go back to sleep and you are thinking and thinking and thinking, just get out of the bed, okay? And then try again. Do something boring or something low energy, and then try again. But don't stay on the bed. Try to avoid anything that causes brain stimulation before bedtime. Okay, including the cell phone, any type of computer, any type of electronics. Okay, you need to avoid that. Avoid naps. However, it's not a bad thing to have a nap, but you need to take the nap at the same time if you are going to do that, and always less than 1 hour. 40 minutes, 45 minutes is okay, and before 3 p.m. Okay, I'm assuming that you go to bed at 10 or 9:30. So don't take naps, don't take prolonged naps, and never take a nap at 5 p.m., that kind of things. Okay, very important to rule out and treat secondary causes. If you don't rule out and treat secondary causes, things are not going to work well. Okay, make sure that before you blame just Parkinson's disease by itself, you rule out secondary causes. Don't forget to like, share, and subscribe to my channel.